Water. Hi, good morning, and welcome to all for this month's the July Journal Club. Today I have a really great pleasure of introducing Dr. Dimitrios Nasioudis, who is now on faculty at the University of Pennsylvania. And the topic of this discussion is going to be the role of systematic lymphadenectomy at the time of interval debulking surgery for patients with advanced stage epithelial ovarian carcinoma who achieved complete gross resection. I should also highlight that Dimitrios was one of the former fellows in our journal as well. So we're really very excited to welcome him, and we look forward to his presentation and also to the discussion of this manuscript. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We are recording today's discussion, and the recordings will be made publicly available. Participants with cameras turned on may appear in the video recording. So we ask that everyone please keep your microphones muted so everyone can hear the presentation. If you're having any difficulties or questions, please send a message in a chat, and our technical support team will hopefully be able to assist you. So with that, I want to again thank you, Dimitrios, for accepting our invitation. Congratulations to having your article selected as the lead article. Always super happy to speak with you. Always learn so much from you. So please proceed and start with your presentation, and we'll then get on to the questions.
Perfect. Thank you. Thank you so much. It's an honor to be here and present our results of our research. And thank you again for the interest in our paper. So our main Our main goal was to investigate the patterns of care and the utilization of systematic lymphadenectomy at the time of interval cytoreductive surgery. And we utilized a large database, the National Cancer Database, which is a hospital-based database that covers 70% of all newly diagnosed cancer cases in the United States. We included patients that were diagnosed with advanced stage 3 or 4 epithelial ovarian cancer. There were cases diagnosed between 2010 and 2015, and they all received neoadjuvant chemotherapy and underwent interval cytoreductive surgery with complete gross resection. We defined systematic lymphadenectomy as at least 20 lymph nodes removed per pathology report. We didn't have any information whether these were pelvic only or plus or para-aortic only. And our primary outcome was overall survival, and secondary outcomes were prolonged hospital stay, 9-day mortality, and planned readmission rates that reflect surgical morbidity. Now, in summary of the results, we identified close to 1,000 patients, and systematic lymphadenectomy was performed in 125 patients, close to 12% of the cohorts. And they had a median of 29 lymph nodes removed with a range between 20 and 72. And as expected, 62% of patients that had systematic lymphadenectomy had positive lymph nodes. Now, in terms of basic demographic and pathological characteristics, patients that had systematic lymphadenectomy were younger, with a median age of 61, and were more likely to have non-serous histology compared to patients that did not have any lymphadenectomy. Now, other characteristics like insurance type, comorbidities, type of treatment facilities were the same between the two cohorts. We did not observe any temporal trends, meaning like the rate of systematic lymphadenectomy was the same between 2010 and 2015. And now, in terms of the secondary outcomes, when we looked at surgical morbidity, as expected, patients that had systematic lymphadenectomy had a high rate of unplanned readmissions within 30 days from discharge, 8.9 versus 1.6%, and also had a longer median hospital stay, 6 days versus 4 days. However, the rate of prolonged hospital stay that we define as at least 10 days was the same between the two groups, and 9-day mortality was rare, and there was no difference between the two groups. Now, in terms of survival outcomes, as we can see in the figure, the curves, overall survival curves were superimposed, and there was no difference between the median overall survival of patients that had systematic lymphadenectomy, 40.4 months, compared to those that did not, 44.2 months. And after controlling for confounders, including patient age, comorbidities, there was no difference in overall survival, and performance of systematic lymphadenectomy did not confer any survival benefits. I think that's it.
Dimitrios, thank you so much for that presentation. And I know that certainly we have a number of questions to bring up to you for discussion. And I also want to encourage everybody in the audience to submit their questions. I wanted to start out by asking, because when you look at the results of the study, you say, well, 12% of patients had systematic lymphadenectomy, and some people would say, oh wow, that's kind of small. But there are others who would say, like, that's actually very, very high. Why are these people actually having systematic lymphadenectomy? So do you have a sense of how frequently this is being done, or what is the standard practice, or what do NCCN guidelines tell us about this?
Yeah, I mean, in the major guidelines, especially after the publication of the LION trial, systematic lymphadenectomy and removal of normal appearing lymph nodes is not encouraged. What is recommended is removing only bulky or abnormal appearing lymph nodes identified either by preoperative imaging or intraoperative by palpation. Now, one of the limitations of our study is, like, we did not have data on the preoperative imaging. So I suspect a number of these patients may have had one bulky lymph node, and the surgeon decided to remove all aortic lymph nodes, for instance. And this is something that can happen in practice. But in general, in the absence of any grossly abnormal lymph nodes, systematic lymphadenectomy is not recommended by any major guidelines. Of course, the data mainly derived from primary debulking cytoreductive surgery, but now there's more data on the interval cytoreductive surgery as well.
Excellent, excellent. So we have some of the questions from the fellows, and I'm looking at Anna's question that I think is kind of also related to the same topic. But Anna, did you want to expand or ask any additional questions as it pertains to this point?
Yes, congratulations, Dr. Nasioudis, for your article. It's a great article. So my question is kind of related, because in your study, only 12% of patients had systematic lymphadenectomy. And the authors already mentioned the trend of systematic lymphadenectomy from 2010 to 2015. But since the publication of the LION trial, do you think that the trend of performing systematic lymphadenectomy is even lower in the interval debulking scenario? Thank you.
Yeah, I think it's even lower. I think people extrapolated data from the LION trial and applied it to the interval cytoreductive surgery. I mean, biologically, it does make some sense. And I think the trends would be even lower. Of course, it's difficult to using large databases to tease out and get granular data to confirm this. But I do think in our institution, for example, we never performed systematic lymphadenectomy for interval or primary cytoreductive surgery after the LION trial.
Yeah, and as a follow-up to Dimitrios, there are some, and I've heard this often in conferences or discussions where they say, well, when you look at the patients who actually did have the lymphadenectomy, a large majority of them had disease in the lymph nodes. Is there not any benefit to removing that disease in those lymph nodes? What would you say to them?
Yeah, we have debunked the therapeutic benefit of lymphadenectomy for endometrial cancer and now for cervical cancer. I don't see biologically removing normal appearing lymph nodes makes sense. Especially if there is microscopic disease also in other places after the surgery. Ovarian cancer is not like you can't get a true R0, right? Like sarcoma, other disease sites. It's a more widespread microscopic disease, and I don't see biologically how removing normal appearing lymph nodes would be any beneficial, especially if patients receive systematic treatment after surgery.
Excellent. So I want to, again, also encourage those in the audience, if you want to submit any questions, you can do it through our chat. Next, we'll go to Rosa Monteros, who has a question for you as well.
Thank you so much. So in the limitation of the study, the author state that information on the status of lymph node in imaging is not available. But in the implication for clinical practice, you advise to remove radiological and large nodes. As an expert in the file, what would you advise in case where preoperative imaging detects pathologic lymph nodes, but there is a good lymph node response on imaging after neoadjuvant chemotherapy? Do you advise to remove them at the time of interval the working surgery or not? In this case, that you advise to remove only the pathologic one or a systematic lymphadenectomy? And what do you advise in case where nodes remain pathologic after neoadjuvant chemotherapy? Thank you.
Yeah, that's a good question. I mean, there's no good data to answer it. However, I would argue that when we perform interval cytoreductive surgery, we don't remove organs based on the disease distribution from the first patient scan before the chemotherapy administration. Like we don't perform splenectomies, colectomies, like based on the disease distribution from the first scan, especially if we have a good pathological response. So I would argue that removing these lymph nodes that have been treated by chemotherapy wouldn't have any benefit in terms of survival outcomes. And also it's interesting, like from other disease sites, like lymph nodes have an importance in terms of immune surveillance and may have implication down the line for the patients in terms of immune surveillance and response to anti-tumor response. So removing these sites may have a detriment down the line.
And Dimitrios, granted, if there is no evidence of lymphadenopathy at the time of interval, understandable, not removing those lymph nodes. What about for those patients where you often will get an imaging study that says, you know, non-specific, potential suspicious lymph nodes in the bifurcation of the aorta? Then do you go chasing after those?
Yeah, I mean, that's a good question. I mean, if they appear grossly abnormal intraoperatively, I would remove them in terms to achieve like complete gross resection. If they're enlarged, you know, definitely with tumor and there's been suspicious pre-op, I would remove them. But I don't think like doing a systematic lymphadenectomy at that scenario would benefit, apart from removing these specific nodes.
Very well. There's a question from the audience, and it says, hey, though. Okay, the question is, do you say, though, pathological positivity of lymph nodes is high post systematic lymphadenectomy, but given systemic chemo is helping in masking the bad effects, i.e. lymph node recovering for it? Not really sure I understand that question. Perhaps the person who brought it up, can they actually just elaborate? Okay, so we can hopefully table that to a little bit later. Dimitrios, next question was from Matteo Pavone, who is in the operating room, couldn't make the journal club. But Arthur, can you proceed and ask Matteo's question?
Yeah, thanks. Thank you, Pedro. Thank you, Dimitrios, for your wonderful article. And I'm just wondering that there was an article about pathallocyanin injection, that is the OTL38, that was published in JCO last year. I believe that is also led by Penn. And I'm wondering if this fluorescence technique has any role in doing lymphadenectomy during and after neoadjuvant chemotherapy.
Yeah, I mean, it is an interesting open label phase 3 trial that was led by one of my partners here at Penn. And in that study, almost 40% of patients had some disease that was identified by OLT. It was like an imaging technique, contrary to like that was not detected by just palpation on white light. And when you look at the breakdown of the additional procedures, it was mostly peritoneal resections. Like from the overall 100 patients that were enrolled, only 5 had additional lymph node dissections based on the use of this imaging technique. Again, it hasn't been, the big question again is, how, before we fully implement this imaging techniques, how does it impact survival outcomes? To my knowledge, there's no like prospective study yet to demonstrate that removing this non-visible disease leads to better overall survival and better PFS. And this is a question that needs to be answered before fully implementing this technique. I mean, we can assume, like with ovarian cancer, there's microscopic cells everywhere within the abdomen, and how would removing like disease we don't see with naked eye would improve outcomes. And this is something that needs to be studied further before implementing these techniques.
Great. And Dimitrios, just a follow-up from the clarification of the prior question. I think it was a little bit alluded to before, but the question was basically, if you have such high rate of positive microscopic lymph nodes after neoadjuvant chemotherapy, and there is no benefit from systematic lymphadenectomy, there's no change in survival in doing so, how do you explain that? Is it that the chemo post-interval surgery, is that chemo basically taking care of those microscopic nodes?
Yeah, exactly. I think it's the chemotherapy that's given after the surgery that also has an effect on the microscopic disease, and that's why we continue with chemotherapy post-interval cytoreductive surgery, and that's the reason we give chemotherapy also after primary cytoreductive surgery, even if we achieve complete gross resection. Also, of course, there's also the immune environment and the T cells that can also like have an effect, a positive effect, but it is the chemotherapy that usually should take care of this microscopic disease after cytoreductive surgery.
Excellent. So we'll go to Turkey. Melis.
Hi, thank you for this amazing presentation. My question is a bit out of the scope of this article, but do you believe that is there any possibility that lymphadenectomy during, considering the advances in sentinel lymph node dissection, what are your thoughts on its future role in the management of ovarian cancer?
Yeah, so I mean, we have gone a long ways in terms of lymph node dissection and gynecologic malignancies, and sentinel lymph node biopsy is now standard of care for endometrial cancer and cervical, implemented in cervical cancer and vulvar cancer. I think ovarian cancer is the next frontier. Lymph node staging is an important and integral part of the surgical staging of ovarian cancer, since we see like up to 20% of lymph node metastasis. But we all know the morbidity of part of lymph node dissection and the how technically challenging can it be as well. So sentinel mapping is the next frontier. It's a little more difficult based on the preliminary evidence that to implement compared to endometrial cancer, but there are already some early phase feasibility studies. I would point the SENTI trial from Italy, from MD Anderson, that was published in IJGC earlier, as well as the SENTI trial from Italy. And the question, of course, is before we implement this technology, we need to standardize it and also test it in a larger phase 3 trial comparable to the Centicle and the FARS trials in endometrial cancer.
Okay,
yeah, the other things also I would add, Melis, is like usually the sentinel lymph node mapping procedure is done to determine if the lymph nodes are positive or not. Here you have a scenario where you know the lymph nodes are positive, and then based on these results, it doesn't matter if you remove them or not. So then it kind of calls into question why identify them? You know they're going to be positive anyway. So you know, what would be the impact on that from that approach? Now the next question is from Osna in Israel.
Hi, thank you. I'm going to join everyone and congratulate you about this publication. And wanted to ask you if you explore the role of the rate of CA-125 elimination, such as the K-LYM score, in predicting which patients may benefit from the lymphadenectomy. And I guess the thought is that if the CA-125 is quickly eliminating, that would be a biomarker for patients who are like HRD patients, and they would be better patients, basically. What are your thoughts about this?
Yeah, I mean, unfortunately, we don't have data from the NCDB about CA125, so we couldn't like calculate the Kelm score. But again, I'm not quite sure, even regardless of the Kelm score, how removing microscopic disease in the lymph nodes would benefit the patient, even if we don't have a big drop or in the Kelm score. So biologically, I can't. It's a little challenging to tie these two pieces together: the Kelm score and the surgical performing a systematic lymphadenectomy. Of course, we know like a Kelm score can be helpful for giving bevacizumab, for instance, based on prior publications, or it could more tailor the adjuvant treatment or the use of maintenance treatments.
And now, Dimitrios, another question that came up is, and I'm sure obviously you've gone through a lot of this data in what's been published. In this principle of the post-surgery chemotherapy, and are there studies that looked at the lymphadenectomy after 6 cycles of chemotherapy? So in other words, if after 6 cycles of chemotherapy, are these lymph nodes, the rates of positivity much lower?
Oh, that's a good question. I haven't come across, to be honest, for studies to give a percentage on top of my head. I mean, theoretically, the more chemotherapy should be lower positivity rates, and typically, like even after surgery, like there's another couple of cycles, 1 to 2 cycles, even if we give 6. So that's a good question. If the more chemotherapy you give, the less positive rates you get of lymph nodes. But I'm not aware of any data on top of my head.
Well, I'd like to take credit for that good question, but that's actually a question from my colleague Tommaso Meschini here from Italy. Anyway, so now we go on to Susan. And hopefully Susan's still connected. Susan was traveling through the journal club. So otherwise we'll ask her question. Susan? There. Wait, Susan.
Hi, everyone. Hi. No, I'll do my best. I hope the connection will last. So my question, thank you very much for the greatest presentation first. And I would like to ask you if do you think there is a possibility that lymphadenectomy performed during the interval debulking surgery still could be beneficial in rare gynecological, in rare histological subtypes of ovarian cancer? And did you look at that, or did you find some data from the primary debulking?
Yeah, that's a good question. So especially someone could argue for a more chemo-resistant disease like low-grade serous and clear cell. Is there a benefit of being more aggressive and removing lymph nodes, especially sometimes clear cell tends to recur in the lymph nodes? We didn't have a big number to perform a meaningful analysis in terms of these rare histologic subtypes. We had looked this question in the primary cytoreductive surgery setting. We published in IJGC, I think, a couple of years ago, and there was no difference in terms of survival among patients with these rare histologic subtypes who had advanced disease but primary debulking and had systematic lymphadenectomy. The data from other centers, they're all retrospective. They're mixed. Some data suggest a survival benefit. Some data suggests no difference. So it is a good question, but we don't have the answer. I don't think we will ever have a randomized trial. In the Lyme trial, it was only, I think, if I remember, like 30% of non-high-grade histologies. But again, in the absence of visible disease, it's a little difficult to biologically justify removing normal-appearing lymph nodes, especially if we pretty much know it's difficult to strip all the vessels from every single lymph node. So yeah, I'm not quite sure even for this scenario how it would benefit the patients.
And Dimitrios, I wanted to ask you also a question that often I've seen brought up in these discussions. If somebody will claim and say, well, look, we know that the rate of positive lymph nodes, if you remove them, is high. You tell us that there is no impact on survival whether you remove them or not. But then you have these patients who actually have a single isolated site of recurrence in the periaortic region. And then, those surgeons or patients will say, hey, look, had you removed my lymph nodes, I would not have had this recurrence. So what is the counter argument for that?
Yeah, I mean, as I said, I mean, we're not quite sure that we're stripping every single lymph node, and then there is also, these are chains, right? Where do we stop? Why do we stop in the renals and go all the way up to the chest, right? And remove all these lymph nodes. And we're not as it's a little more challenging compared to like the germ cell tumors and like the testicular, where they strip all the vessels back, forth, like everything. And I don't think like even if we are that aggressive, we'll get every single lymph node. And I can't see biologically that it would make sense. And again, if we have a single recurrence, there's also the secondary cytoreductive surgery to remove that specific lymph node. And why would we put a patient through this morbidity, right? Because if we want to strip all the vessels, we have blood loss, we have ICU admissions, we have reoperations in order to prevent one recurrence in the isolated recurrence in the lymph node. When we treat it, we have a disease that is primarily peritoneal, spread peritoneally.
Great. And then to as a follow-up to that, I mean, and now you're coming on to being a new faculty, and you see a patient that has a 3-centimeter recurrence just underneath the inferior mesenteric artery in the periaortic region. And you have your fellow with you, and you obviously are removing that large lymph node. Your fellow asks, why don't we remove the ones above and the ones below? Because what's the likelihood that immediately above and immediately below, they're going to be completely normal? And this is the only time that this is the only one that has a recurrence.
Again, I mean, if you have it's all changed. Where would we put the stop, right? Which lymph node we're going to pick and say, you know what, I think the cancer stops here, and why don't we go even further up? I mean, and in this scenario, we would still give chemotherapy, right? So that will take care of any other microscopic disease. So I wouldn't subject a patient to increased morbidity of full lymph node dissection when we're removing the bulk of the disease, the bulking lymph node, and we're giving also adjuvant treatments.
Excellent. I will turn now to Natalia from Austria. She has a question for you.
Thank you. Also, congratulations from my side. The goal of my question is to sum this a little bit up. So, of course, we all know that every retrospective evaluation has some weaknesses, but do you really think that we need further studies to say that lymph node removal does more harm than good in these patient populations? Also, when we, of course, think not only of your work and study, but also of the Lion trial, or I think in the podcast you mentioned the Caraco trial. That was new to me. What do you think about this? Do we need more studies on this topic?
Yeah, I don't think we need more studies to prove that removing normal appearing lymph nodes in advanced stage ovarian cancer, which is a primarily peritoneal disease, alters the prognosis of the patient. I think the Lions trial, multiple retrospective studies, including ours, and the Caraco trial that was mainly conducted in the interval cytoreductive surgery, have proven that there's no overall survival benefit. And we subject the patients to increased morbidity with reoperations, high reoperation rates consistently across all studies, higher blood loss and like injury to the vessels. So I think we should put our efforts in other questions than looking at removing normal appearing lymph nodes. I think we can put that to rest.
Excellent. Very well, Dimitrios. And a couple of questions from Payam. I see him on the screen, so I'll let him ask his own questions.
Thank you so much. Great presentation. And now I just have to kind of read. One of the questions I have is that obviously you see there are conflicting results when it comes to doing ICG sentinel mapping for in high-risk endometrial cancer cases, which means that sometimes, even though they're not positive, when you do the sampling above the, let's say, left renal, you have nodes that are positive. How does this impact the same thing, or does this apply in ovarian cancer when you do the sentinel mapping, and potentially you would be missing those that are actually positive? That's my first question. And my second question is also, if we have all these positive notes, which I agree with you 100%, are we really doing R0? Is R0 something that's completely achievable when you have nodes that are potentially positive, and we're basically proposing not to take them out?
Yeah, I mean, to your second question, I don't think in ovarian cancer we ever get R0 in the same sense we get R0 with other cancer sites like sarcoma or colon cancer, for instance. Like it's a microscopic disease, spreads peritoneally. There's always microscopic cells left behind. So the terminology R0 does not technically apply. Complete gross resection we do achieve, and that's attainable with aggressive cytoreductive surgery, but removing microscopic disease in ovarian cancer, I think it's not achievable. And of course, it's this, as I said, in terms of the imaging studies, that's also the question. Does being more aggressive and removing disease we don't see, does it change the prognosis of the patient? That's something we have to test. But to your first question, I mean, I think the sentinel lymph node mapping in early stage ovarian cancer is in infancy. I think we need to see more data to standardize the procedure and see more data before applying in everyday clinical practice. There's only a handful of studies, and the technique has not been standardized, and it needs more work and it needs more collaboration between multiple centers, given that these patients are more rare compared to the endometrial cancer, before we apply this technology. But yeah, these are valid questions, like, is there a skip metastasis in ovarian cancer in terms of lymph nodes? What's the best injection site? What's the best injection technique? We have to use only ICG, TC99, both, methylene blue. There's other studies, for instance, what would be the optimal technique for ovarian cancer? And this is something that we have to work on. It's probably the next frontier in terms of surgical excellence and innovation in ovarian cancer.
Great, thank you, Dimitrios. And as a summarizing statement from the chat, the question is, can you briefly summarize early stage, advanced stage? In early stage, should we routinely perform systematic lymphadenectomy? And in advanced stage, at the primary and in the interval, only if there are enlarged lymph nodes. Is that correct?
Correct, yeah. I mean, early stage, like the lymphadenectomy is an integral part of the staging procedure. It's up to 20% of patients have lymph node metastasis, especially when we look at high grade, of course. And that will alter the adjuvant treatment recommendation, has prognostic implications. So that's an integral part of our surgical armamentarium. Now, for advanced stage, when we have disease outside of the pelvis, when we have like microscopic disease in the abdomen, removing normal appearing lymph nodes does not alter the prognosis of the patient, does not give us any additional information, and doesn't change the adjuvant treatment or the maintenance treatment plan. So in this scenario, we have to remove only lymph nodes that appear abnormal, either in the imaging or intraoperatively.
Excellent. And then one last question, Dimitrios, that's coming in, was regarding actually back to the methodology as the number of lymph nodes. Like, where does 20 come from? Is 19 not a good lymphadenectomy? Is 21 a great lymphadenectomy? So where does that come from? And it doesn't matter. And, a lot of times the surgeons will say, yeah, I did a lymphadenectomy, and it's like 3 lymph nodes. So then where do these numbers come from?
Yeah, I think that we set it arbitrarily. I mean, we had to set it somewhere to define it as systematic lymphadenectomy. Other studies that define 10, 20. The median number in the Lions trial was much higher, like lymph nodes that were harvested. So we just arbitrarily picked 20 to have to exclude patients that had like only 2 lymph nodes or 5 lymph nodes, because probably these patients had grossly abnormal lymph nodes, right? So we wanted to exclude that patient population. We didn't have data on the pre-op imaging, so we didn't know which patients had abnormal appearing lymph nodes before the surgery. So we had to somehow define and exclude these patients from our analysis to have a more homogeneous population. But yeah, to answer questions, there's no like strict definition of what is comprehensive, what is not. I think like there's a manual that defines it as 10, but we all know sometimes the patient doesn't have that many lymph nodes. We remove everything and we only get 5 lymph nodes and there's nothing left behind. In other cases, we get 20 lymph nodes as microscopic for the same amount of effort. So it just can vary as well based on the patient anatomy.
Excellent. Very, very well. So it didn't come from the limit of drinking age in the United States, 21 or less. You cannot drink 21 or more.
Yeah, so I picked 21.
All right. Very well. So thank you so much, Dimitrios, for your time. Again, congratulations on this work. Congratulations on all of the work that you have already contributed. Just in your, before coming on faculty, just in your fellowship, some really landmark studies already. So really very, very impressive. I also want to announce that the recordings of today's session will be available on the IJGC, IGCS, and ESGO websites. And also to remember to join us in the August Journal Club to discuss mirvetuximab in platinum-resistant ovarian cancer, the final overall survival and post-hoc sequence of therapy subgroup analyses of the SORAYA trial. So thank you so much, Dimitrios, once again, and thank you all for joining, and thanks to the fellows for asking those really excellent questions.
Thank you, everyone. It was an honor. Excellent questions. Bye.